Hi guys, this is Khadija and I'm here with the second installment in the pathology series, and the topic of discussion will be inflammation and wound healing. So what is inflammation? We must just remember that it's a protective reaction. It can be caused by endogenous or exogenous stimuli, but it's a protective reaction. And to summarize, what happens is the agents are either diluted, destroyed, or walled off, but sometimes this reaction can even become harmful for us. And inflammation can be classified. It can be classified according to the length, the mechanisms, the histological features, or the causative agents. By length, it's either acute, where you will see more neutrophils, or it can even have like a hyperacute stage or subacute stage, before and after acute, basically. And yeah, you will see neutrophils. If it's chronic, you will see more lymphocytes and macrophages in the region of inflammation. In the classification according to mechanisms, the three mentioned here, they're all present, but in different intensities, and depending on the predominant component, they're named. So in alteration, there is tissue change. For example, in viral hepatitis, polio, diphtheриal myocarditis, you will see alteration. And then there is exudation. In this, there you will find like an inflammatory exudate with there is like liquid plus proteins. That's an exudate. If it's cellular, it's called an infiltrate. And an example could be pericarditis or pleuritis. That's where you would find an exudation sort of inflammation. And third is proliferation, where there is formation of granulation and fibrous tissue, for example, in chronic cholecystitis. It can also be classified according to histological features, and the vast majority is non-specific. It's not possible to trace the etiology, but there is also specific granulomatous inflammation, which is found in tuberculosis, in leprosy, syphilis, tularemia, so many others, brucellosis, cat scratch, sarcoidosis. Yeah, but yeah, and still the vast majority is mostly non-specific. And lastly, causative agents. You can either find septic or aseptic. Septic is caused by microbes. Septic inflammation has a protective character. You must remember, septic, protective. And aseptic, which is a sterile inflammation, has a reparative character. It's for reparation. For example, in chemicals, burns, or radiation. Yeah, so you must keep that separate in your head. And yeah, so what are the basic clinical manifestations of inflammation? There can be local or systemic. So under local, we have calor, which is heat and warmth, rubor, redness, erythema, tumor, swelling, dolor, pain, and functionalasia is function loss, impairment. Yeah. Under the systemic manifestations, we have fever, which is irritation of the thermoregulatory center by tumor necrosis factor or interleukin 1 and 6. It's the only visible systemic manifestation. Or we can have a high erythrocyte sedimentation rate or leukocytosis, where there can be increased white blood cells 30 to 40 times 10 to the power 9 per liter, which is basically called a leukemoid reaction. It's almost as high as leukemia, and there is a left shift of the Hynex number due to an increased activity of the bone marrow. So what you will see if there is bacterial infection is neutrophils. If there is parasites, eosinophils, and if there are viruses, you will find lymphocytosis. And so next can be leukopenia. You can have leukopenia where there is a decreased number, and this can also happen in viral infections, in salmonella infections, rickettsiosis. Yeah. And lastly, we have immunologic reactions, which is basically you will find acute phase reactants. You've heard about this in physiology, the C-reactive protein complements secondary systemic amyloidosis of chronic inflammation, SAA, and fibrinogen. So inflammation, like we discussed earlier, can either be acute or chronic. So in that context, what is acute inflammation? It is a very early response, and here microcirculation plays a very important role because the capillary supply is basically what is supplying us the white blood cells, the interleukins, and the fibrin. And so we can divide this into two parts: vascular changes and cellular events. Under vascular changes, initially you will have arteriolar vasodilation, because of which you will see the redness, feel some warmth, and this is because of the histamine release. Then there will be an increased permeability of the veins, and here you will find widened intercellular junctions, retraction of the endothelial cells, which is also because of the histamine, protein-poor transudate, which will cause the edema, protein-rich exudate if it's more than 1020. And lastly, you will also have endothelial injury, which is direct or leukocyte-dependent proteolysis, and there will be protein leakage, then there will be adhesion of the platelets, and you will eventually have it. Moving on to the cellular events. After the vascular changes, this is all to help the cellular events, so there has to be some sort of movement of the leukocytes so that they can reach into the site of the inflammation. And for this purpose, I will display a picture on next, but it's more complicated, so it's just to help you imagine. You don't need all the detail there, but yeah, there is going to be some sort of leukocyte margination. They will roll, they will adhere, and then finally they will have transmigration by diapedesis. And this initially happens in the first 2 days. It's the macrophages, the neutrophils. Macrophages and neutrophils can be used interchangeably. They're the same thing. They move in the first 2 days, and as the acute becomes chronic, monocytes or macrophages move in the next 2 to 3 days. This margination, of course, is initially initiated by the chemotaxis, some release of signaling molecules. It can be endogenous, like the interleukins, leukotrienes, C5a, and it can also be exogenous, which is toxins or bacterial proteins. And then there is also phagocytosis. Once these white blood cells reach the site of the inflammation, there is recognition and attachment. It's facilitated by opsonins. We've studied about this in physiology. And there is engulfment by the pseudopods formation. There is a phagocytic vacuole, and then the lysosome fuses, and we have a phagolysosome, and then we have killing and degradation by oxidative burst. And there will be passive migration of red blood cells as well because of the permeability of the walls, but it's not like there is no contribution of this event to the inflammation as such. So how does acute inflammation end? What is the result of the previous events discussed? So it can either resolve completely and the inflammation can be finished and the situation can be back to normal. The tissue can be back to normal. This is in limited injury. For example, small localized inflammation in folliculitis. The chemical substances can be neutralized and the vascular permeability can be reversed. There can be apoptosis of the inflammatory cells and increased lymphatic drainage, and the issue is solved. But if you can imagine a situation where there is a big wound on your leg and there is some sort of infection there, you will have tissue destruction. There will be fibrinous inflammation because your skin needs to come back together, so you will have adhesions, fibrosis. Or because of an infection, you can have purulent inflammation. There will be abscess formation there, some pus, and yeah, that will take longer to heal. It will be weeks to more months. So basically, it can eventually get into progression into chronic inflammation as well. So moving on to chronic inflammation. Does chronic inflammation always happen after acute? Not necessarily. There can be different reasons why there is chronic inflammation. We can have a primary chronic inflammation. From the very beginning, it is chronic. There is no way this could have been acutely resolved, basically. This is when the infective agent is of low virulence. It can survive longer in you. Or there is sterile inflammations, for example, silicosis. Or it can be an autoimmune reaction, like rheumatoid arthritis, glomerulonephritis, multiple sclerosis. Thirdly, it could even be a persisting infection or prolonged exposure to irritants. intracellularly surviving agents that are not easily resolved by acute inflammation. It's hard. So under that comes tuberculosis, or there can be Scheffler's tumor, which is a reaction against surgical stitches, foreign body reaction. And lastly is basically repeated acute inflammations in otitis or rhinitis. What is of highest importance in chronic inflammation is the inflammatory cells, the type found. It's called round cell infiltrate, and what you will find is basically lymphocytes, both T and B, and eosinophils if the infective agent is a parasite or it's caused due to an allergy, and monocytes and macrophages that are activated to epithelioid cells by various mediators. Next, I would like to discuss a few types of inflammation. Firstly, we have serous inflammation, and it's a very exudative type of inflammation where you'll find a thin, clear exudate with a very high protein content. You can find this, for example, in rhinitis, where you have a watery nose. That's the easiest example, but you can also see this in some types of pericarditis, pleuritis. Next, we have fibrinous inflammation. Here, because of higher vascular permeability, there is exudation of fibrinogen, which converts to fibrin. And because of that, macroscopically in this sort of inflammation, you will find soft, yellowish, butter-like fibrin, and it can cover a serosal surface. And it can be thin, or it can even be several millimeters thick. Under the microscope, you will find eosinophilic fibrin appearing in fine threads in a network or a solid mass. An important example where this inflammation is found is in fibrinous pericarditis. This condition is called corvillosum or hirsutum, which is basically hairy heart because of bread and butter appearance. It can occur as a complication of myocardial infarction or viral attacks or rheumatic fever even. If connective tissue replaces fibrin, basically that's called organization, there is a fibrous capsule in the pericardium, and this can lead to constrictive pericarditis. So if we have fibrinous inflammation, what next? How does this resolve? Well, it depends on the thickness of the fibrin layer. If it's thin, it usually resolves by fibrinolysis and the remaining fluid is removed by the capillaries. But if it's a thicker layer, it resolves by organization, by the granulation tissue. And so fibroblasts move into the fibrin. There is specialization into endothelium, formation of new capillaries, but the focal thickening, it remains in the epicardium. So there is going to be fibrous adhesions, basically scar formation, and in overall result, the pericardial cavity becomes occluded by this fibrous capsule, and yeah. Next we have suppurative inflammation. It's basically a purulent pus-forming type. There will be a lot of neutrophils in this inflammation, and it's mostly by pyogenic bacteria, for example, staph and strep. Etiology. We must remember that this can either be superficial or deep. So if it's superficial, for example, folliculitis, it's limited to the skin or just a layer of mucosa. But if it is deep within the tissue, for example, an abscess or a phlegmon, how did this happen? Superficial can go deep, or because of some trauma, there was direct implantation of the bacteria deep into the tissue, or it was carried there hematogenously or by lymph. So we have a few types under suppurative inflammation, and understanding that they're different from each other is very important. Phlegmon or cellulitis, one and the same. It's basically interstitial, diffuse interstitial. There is no collection in a cavity. On the other hand, abscess is a localized collection. So this could be at the site of the wound, but it can also be pseudoabscess, which is basically pus in the lumen of a hollow organ, for example, the appendix. And then we can have also empyema, which is accumulation of pus in preformed cavities. For example, here we would consider thoracic cavity. Next, we can also distinguish between the development. So basically, if it's acute, when there is an acute suppurative inflammation pus, basically the pus is just there, so it's bordered by its surrounding tissue. But if it's chronic, eventually there will be a pyogenic membrane, basically a fibrous capsule, a hardened capsule, and inside it you will find the pus. Now, suppurative inflammation can have quite a few complications. You can think how it's liquid. The bacteria is present in this little pool, so it's easier for it to move through the body elsewhere and, yeah, create the problems that I will discuss right now. For example, firstly, we will have suppurative fistulas. This is a very common complication. You can have formation of fistules, or we can have bacteremia. Now, bacteremia does not have any symptom yet. This is not sepsis basically yet. So, because it does not have any symptoms, it can create secondary foci of inflammation. The bacteria can move through the bloodstream, and it can eventually then cause sepsis because of massive bacteremia. The content of bacteria in the blood is a lot. By then, you will have the fever and all the rest. You will have a shock, basically. Or then we can have infective endocarditis because of this bacteremia. It can reach the heart. Or we can have thrombophlebitis because of inflammation of the veins wall. So if you know Bruch's triad, one of the elements for forming the for thrombosis is basically damage of the wall. So that's what happens here. And depending on the location where, like, which vessel is being affected, we can sort of like connect where the next foci is basically. So for if the infection is central, for example, from infective endocarditis, the the spread can be to the whole body. But if it was peripheral, if the initial spread was from thrombophlebitis, for example, this can spread to the lungs. If it was portal, it can spread to the liver, and if umbilical, to the liver as well, but this happens only in the neonates. And one last complication of suppurative inflammation is also lymphangitis, inflammation of the lymphatic vessels, or lymphadenitis. Next, we have pseudomembranous inflammation. This is basically a response to a very powerful necrotizing toxin. It causes much higher vascular permeability, so there is again exudation of fibrinogen, which is converted to fibrin. And what is the pseudomembrane composed of? It basically has fibrin, necrotic mucosa, the etiologic agents, the pathogens basically, and leukocytes. So examples where you will find pseudomembranous inflammation is the Corynebacterium diphtheria infections. There you will find pseudomembranes on the tonsils and the pharynx. In childhood, death can be caused by suffocation, by airway obstruction, and the endotoxin here can also affect myocardium selectively. So it can cause heart failure by myocarditis. Extra information. Next, we have Shigella dysentery. Here, enterocolitis of the large bowel. There can be bleeding, but basically there is a pseudomembrane. Then this can proceed to ulceration and perforation of the large bowel too. We can have candida infections where, for example, glossitis and esophagitis. You will find a detachable yellow-white pseudomembrane which can cause an ulcer and eventually heals by scars. And we have Clostridium difficile, which we have all seen in sketchy. And lastly, we have gangrenous inflammation. It's basically a secondary modification by bacteria. So, for example, we have appendicitis or cholecystitis, or also malignant tumors of the GIT. There is a very high risk of perforation. So, in all these cases mentioned above, you can have peritonitis. And in wet gangrene, the tissue is yellow, soft, necrotic, and swollen. It's caused by putrefying bacteria. But in gas gangrene, we've also heard about this in microbiology. It's caused by Clostridium perfringens mostly. What is essential is it's mostly accompanied by necrosis. To slightly also brush over specific inflammation, it's granulomatous, and it's a distinct chronic inflammation type. There is delayed cell-mediated immune reaction here. You will find aggregates of activated macrophages, which are the epithelioid cells. They differ in different types of the inflammations, basically, depending on the etiology. You will also find a lymphocytic rim here. There is no agent elimination. The best example here is when you consider tuberculosis. There is no agent elimination, but there is walling off. And here are a few examples of specific inflammation. There is a detailed description. You can pause the video and have a glance, read through it, and yeah. Specific inflammation it's not restricted just to bacterial infections. It can also be by parasites, fungi, or other inorganic metals or dust, foreign bodies, or unknown, basically. Moving on to wound healing or repair, I would first like to clarify the difference between a few terms. Regeneration is replacement of the previous tissue by the same type of tissue. There is no change in the final product, basically. So it needs basement membrane of the epithelium. For example, if you were talking about recreating the reticulin frame in the liver. But then there is reparation, which is replacement of tissue by connective tissue scar. This is fibrosis, basically. What is repair? Repair is regeneration and reparation in combination. There cannot be healing with just one. They both come hand in hand. As you would have guessed, regeneration takes some time, so the initial response to the wound after resorption of necrotic tissue is basically formation of granulation tissue. This process involves 4 steps. So you will have formation of new blood vessels, angiogenesis all over the wound. Then there will be migration and proliferation of fibroblasts filling and bridging the wound. There will be some deposition of extracellular matrix, and in this step you can have some other secondary changes like dystrophic calcification. And finally, you will have maturation and reorganization of this fibrous tissue into a scar. This is remodeling by matrix metalloproteins and so on. This is because, of course, regeneration cannot do the repair solely by itself. So the macroscopic appearance resembles those steps mentioned above. You will find a very high vascularization. You will find high cellularity. There will be a lot of fibroblasts or inflammatory cells present as well. There can be myxoid matrix of the loose extracellular matrix. But how much regeneration you can have also depends on the tissue type. So in repair, in wound healing, it also depends on what tissue is actually being spoken about here. So we have 3 types. We must remember these. There is permanent, stable, or labile. Permanent is basically non-proliferative in postnatal life. There cannot be regeneration of neurons, cardiomyocytes, and skeletal muscle. Very important. Do not forget neurons, cardiomyocytes, and skeletal muscle. They are non-proliferative and they will not regenerate. Basically, you will not have new cells of this type forming again. Then we have stable, and here we do have regeneration as a response to injury, which is basically the parenchyma. We're talking about parenchyma of all these organs like liver, pancreas, the kidneys, mesenchymal cells, endothelium of the vessels. And lastly, we have labile, continuous regeneration from stem cells. And as you could have guessed, it's mostly the hematopoietic cells, the surface epithelia, duct epithelia, mucosas. And I would also like to touch on some pathological aspects of healing. These are some terms you will come across. For example, proud flesh or caro luxurians in Latin. It's basically excessive amounts of granulation tissue. Then you can have keloid, excessive amount of collagen, hyaline plaques, which are found on serous membranes, and a small note on cutaneous wounds. They can either heal by primary union or secondary union. So I would like to display a picture. So primary intention is basically there is no granulation tissue between the wound, like they just join. The 2 edges of the cutaneous wound joins. But secondary intention, secondary union is basically where you will not have the gaps pulling together, but they are filled with granulation tissue. as you can see in this picture. Lastly, repair can sometimes include metaplasia. Basically, there will be replacement of one type of mature tissue by another type of mature tissue here. And the typical example is epithelium. In, for example, the respiratory system in smokers, you will have ciliated columnar epithelium replaced by squamous epithelium. And in the urinary system and gallbladder, it can also be replaced by squamous epithelium. This will be all. It's simple basics of pathology, and I hope it was easy to understand. Please leave a comment below if there was something unclear or you would like to question something. And yeah, thank you for watching.